Hey, welcome back to the Health Bridge. Dr. Pedram here with Dr. Tammy, and we're going to talk about migraines today. And yeah, it's a thing. It's a big thing. Millions of people suffer from it, and we have a renowned expert, Dr. Stephen Graff-Radford, who's over at Cedars-Sinai, dentist. Who, and we'll talk about why, as a dentist, he's actually capable of being an expert in this because of all the nerves and the stuff that goes around there. Adjunct professor at UCLA Pain Management Center. He's over at Cedars-Sinai, written over 150 articles, book chapters, and scientific abstracts on the subject, and his focus is the study of neuropathic facial pain and headaches. Doc, welcome to the show.
Thank you very much. Thanks for having me.
Yeah, excellent. So let's get into what defines a migraine versus a regular headache so that we can start circling around the subject.
Well, the simplest way of defining migraine is to look at the criteria that Richard Lipton brought up, which is, number one, a disabling headache that's associated with nausea and light sensitivity. Those are your three major criteria. But if you want to be more specific about what a migraine is, the International Headache Society has classified it as a headache that lasts anywhere between 4 and 72 hours. The exception is in children, where it can be less than 4 hours. And then it requires two of the following four criteria. Number one, unilateral, one-sided, comes from the Greek term migraine or hemikraine, half a head. So it's usually a one-sided headache. And so that's your first criteria. And the second is it's a throbbing pain or a pulsatile pain. It's moderate to severe in intensity and worsened with physical activity. So you need two of those four, and then you need one of the following: nausea, vomiting, light sensitivity, and noise sensitivity combined. And provided you fulfill those criteria, it's a migraine. Now, just out of interest, the majority of patients who will go to a physician with a complaint of headache, about 95% of them have migraine headache. And unfortunately, they're not all diagnosed. Less than 50% of them are diagnosed. They usually are misdiagnosed with either sinus headache or tension type headache. But the disabling headaches that take patients to the doctor are by and large migraine.
So what are the kinds of things that cause a migraine to occur? And is it lifestyle? Is it food? Is it both? Is it genetics? How do we get these?
So what we really understand now is that migraine is a genetic disorder. There really are no clear genes that are defined for migraine as we know it, but for certain subtypes of migraine, the genetics is quite well worked out. But we do know that the majority of people who have migraine have a parent or a grandparent who've had migraine. And so we really believe that it's genetic. And if you can imagine that based on the genetics, there's an area of the midbrain that's constantly active, and we call that the migraine generator. And we can see that on certain forms of imaging of the brain, functional brain imaging. We can see this area constantly active, but it's not creating pain because that so-called generator or boiling pot is under the control of a brain switch-off system or a brain inhibition system. And if the brain inhibition system is working properly to put the lid on the pot, we don't have a headache. If something adversely affects the inhibition system, then this generator releases a variety of peptides or chemicals around the lining of the brain that causes the throbbing pain. So something has to affect the switch-off system, and that could be any number of things. Well, we have to remember that migraine is more common in women than it is in men. About 17% of the United States population of women have migraine, and about 7 or 8% of the male population. So that in itself says something. And therefore, estrogen is clearly linked to migraine. So when we think about when do women get migraine, it's during a drop or a change in estrogen. A reduction in estrogen triggers the migraine headache. So that's one trigger that you might think of. Other common triggers, change in barometric pressure. This weather that we're going through here in Los Angeles now with the cloudiness and then the hot day the next day is terrible for migraine patients. Anytime there's a change in barometric pressure, it's a real problem for them. certain foods, particularly things that are brain stimulating, like caffeine or tyramine found in cheeses, or certain agents found in chocolate, and some of the delicious
Not
things.
chocolate.
Exactly. Some of the delicious things are likely to trigger the nitrates found in pressed beefs and deli foods and things like that. The sulfites in wines, anything that stimulates the brain might be a triggering factor. Stress, emotional factors, lack of sleep, too much sleep, and so on and so forth. So it's very difficult to only find one specific trigger in a patient, but we try to explore them as best as we possibly can.
Oh my goodness.
It's amazing we don't all have migraines.
My head hurts. Coming on right now. Yeah, it's so hard when you talk about genetics, and everyone's talking about epigenetics right now, right? And so how our food and our lifestyle and these things can actually help the expression of certain genes. Has the research gone there quite yet? I mean, are we still looking at triggers and how to put out these fires, or have we gotten to the place where there's certain foods that can trigger an epigenetic stack towards maybe not having migraines?
Well, what we certainly are doing is we're moving in multiple directions to understanding genetics. Number one is, what is the gene that predisposes you to have migraine? And then more importantly, we're looking at genetics a lot now in selection of treatment or selection of pharmacology, medications, specifically related to how your body metabolizes drugs. You can look at the means with which most drugs are metabolized through the liver is through what's called the P450 cytochrome system. And then that has multiple, about 7 or 8 different pathways that are clearly genetically linked. So we can do now an oral swab of the mouth, and we can define the genetics of that particular patient's cytochrome system. And then we can choose drugs that they're more likely to metabolize correctly. So in other words, there are 3 types of metabolism that one can get: normal, where we just normally metabolize, or we're low metabolizers, mean that the drug builds up in our system, so we need less drug to get an effect, or those drugs are more likely to give side effects. Or you're a hypermetabolizer, where you just chew up the drug and get rid of it. And so you can now begin to choose medications based on that understanding of genetics. So again, as I'm saying to you, there's multiple different options for us to explore genetics and to try and define it. Further, we're looking at how these genes propagate in the brain and select drugs that specifically bind to modify that genetic process. But it's very much in its infancy, that whole process.
So drugs are part of the treatment, but I know that you have even more things that you work with other than oral medication. Can you tell us some of the treatment options for these people who suffer from these really debilitating migraine headaches?
Well, again, we look at a multidisciplinary approach to the management of headache. We spend quite a lot of time dealing with lifestyle. So we start out with patients keeping a diary for us, and that's an eye-opener, because so often patients will come in and they say, oh, I get 4 migraines a month. And then you give them a diary and they're having a headache almost every single day, but they're not calling that a migraine. And they're taking their over-the-counter medication, their Excedrin or their ibuprofen or whatever they've chosen. I call it the Costco therapy. You go to Costco and they've bought their gallon drum of their favorite agent, and that's not really a medication. They don't even tell the doctor about it, because it's available at Costco. So it must be just fine. But what we do know now is that if you're using symptomatic medications, even if it's an Excedrin or a Tylenol or an ibuprofen, more than 2 or 3 days a week, it will cause a rebound headache. So keeping a diary, looking at the frequency of headache, looking at medication usage becomes very important. Then we look at diet. And diet, obviously we mentioned the common foods that trigger migraine, but there's some interesting information on diet. If you do a radical diet of any kind, you cut out sugar, you cut out dairy, you cut out gluten, you cut out protein. It doesn't matter what radical diet you tend to do. It seems to make a huge difference to migraine. It reduces migraine frequency. So we often look at diet and make significant modifications in diet. Sleep. The sleep cycle is very, very important. One of the natural causes of aborting a headache, getting rid of a headache, is going to sleep. If at all else fails, if you can sleep for a few hours, you're going to wake up and your brain's reset and your headache's pretty much going to be gone. Your migraine's going to be gone. But sleeping on a regular basis, waking on a regular basis is very important. We often look at apnea. We're a slightly heavy population, as you all know. We realize that the greater the weight is a major factor in the increased perpetuation of migraine. Body mass index is directly correlated to increased frequency of migraine. So we try and get everybody to lose weight. But coming with that increased weight is often apnea, where we snore and then we hold our breaths and choke in the middle of the night. And the patient who has the apnea doesn't know anything about it, but the spouse hears it and is often frightened. Right? But we see a marked increase in the frequency of migraine with apnea. So that's another area that we look at when we're addressing sleep. And then again, exercise. These are all factors that we put into dealing with managing migraine. We do involve our psychologists in the center to do biofeedback and relaxation training, cognitive therapies, all of which fall into the sort of non-pharmacologic options for patients and can be very, very effective overall.
I've had a number of patients that were very sensitive to environmental triggers over the years. Like you get into an elevator with someone who's wearing a cologne or a perfume and it triggers. Can you speak to that? Because it seems that the frequency of these types of headaches is also increasing as we layer on all these chemicals in our environment.
Yes, and we have so many patients who cannot even open up a magazine because the magazines have the perfume sachets in them, and they can't walk into a department store because what's on the ground level of a department store is the perfume, right? To the department store when you get your migraine headache. So again, that's all due to brain hyperexcitability. The migraineur has a hyperexcited brain. So light can trigger the headache, noise can trigger the headache, smell can trigger the headache, foods can trigger the headache. So again, these are the common triggering factors again in headache, and because of brain sensitization and brain activation. Which brings up an important point, talking about brain activation. Some patients with migraine have an aura. What is an aura? An aura is a well-defined visual change that usually starts in the middle of the visual cortex. It's like a zigzag pattern that's seen in the visual cortex, a flickering light or a flashing zigzag pattern. It starts in the middle of the visual field and it progresses its way out, usually moving at about 2 to 3 millimeters per minute. And it's associated or known now to be due to an electrical activity that spreads over the brain. As this brain depolarizes from the occipital cortex or the visual cortex, so the patients experience this visual field change, and often they lose their vision, they can feel a tingling in their hands, etc. So again, that's another sign of brain excitability, and it occurs in about 10% of patients with migraine, about 10% of the time. So not everybody who has a migraine has to have an aura.
So we talked about your multifaceted approach. One of the things I'm particularly interested in is the injections. There's Botox, there's other means of treating these, and they're actually a little bit preventative because the Botox treatment lasts many months. Can you speak to that?
So Botox is a really nice story. There's a plastic surgeon in Beverly Hills, Dr. Binder, who was injecting his patients many years ago in the early 80s with Botox for cosmetic reasons. And the patients would come in and say, oh, my migraines are better. And so he published it. And then the scientists went out to try and prove that Botox worked. And they did 12 studies, placebo-controlled studies, to prove that Botox worked, and they couldn't prove it. Now, the reason they couldn't prove it is they were choosing patients who had relatively infrequent migraines, less than 6 headaches per month. And it was only about 5 or 6 years ago that they realized that in order for Botox to work, the brain needs to be more sensitized. Because the way Botox actually works is it decreases the neural excitability. We believe that it works through controlling the peptides in the brain. Okay, and so then they studied it in what was called chronic migraine. So chronic migraine is migraine headaches occurring more than 15 days per month. And when you use Botox in that population, there was a greater than 50% reduction in headaches in 12 weeks following doing it, and was statistically superior to placebo. And therefore, it's now been FDA approved for that particular population. Very effective means of treatment, and you require injections every 12 weeks. And you should do it at least twice, even if it doesn't work the first time, should be repeated at least twice. And it's often additive. The more you do it, the more effective it becomes.
Well, and that was the first use, wasn't it, of Botox? The Carruthers in Vancouver, BC, they were treating tic douloureux. So we know it works on pain. So this is exciting so where is it placed? Is it placed where they have the headache on one side? How does that work?
Yeah, well, it's still not 100% worked out how it works. There's a scientist in Boston by the name of Rami Burstein, and he's done some animal model trials with Botox, suggesting that it's actually taken up by the trigeminal nerve, the sensory nerve of the head and face, and transported to the brain where it creates its function. And so if you can place it in multiple areas close to neural systems is probably how it likely works. Initially, it was thought maybe it had an effect on the tension of the muscle because of its muscular effect, but it's probably not that at all. Nevertheless, the protocol that's FDA approved is a very specific protocol. It requires 5 units of the toxin to be injected into 31 points in the forehead, in the temples, in the occiput, the back of the head, and in the cervical spine, in the neck, and into the shoulders. So you do 31 injections symmetrically, so that in the forehead it looks symmetric. It doesn't look like you've got a droopy eye or whatever else. And through that process, it's been very effective overall.
So this migraines are an interesting subject in alternative medicine because you'll have patients that'll come in and say, look, I'm on Imitrex, I'm on all these things, I don't want to be on these drugs for life. And so there's behavioral therapy, there's neurofeedback, there's acupuncture, there's all kinds of things that everyone's trying to help these people. It's a very, very difficult patient population because they're in so much pain. What have you seen kind of across the board that's worked either adjunctively or just surprised the hell out of you when you've tried everything kind of across the board in complementary medicine?
One of the things I love about complementary medicine is that it's complementary, is that nothing is perfect in our pharmacotherapy, nothing is perfect in our diets, and nothing is perfect in any area. So it's really lovely to have complementary options. So the first area I look at in complementary medicine are the vitamins, minerals, things like that. And the agents that work very well are magnesium, 400 milligrams of magnesium, riboflavin, 400 milligrams. Those are my 2 go-tos. And there's another one called Petadolax, Butterbur, 50 milligrams, coenzyme Q10, 150 milligrams. Those all work very, very nicely as an adjunct to your overall process. The next area I think really works very well are, and has been proven scientifically, are things like biofeedback, cognitive behavioral therapies, relaxation training, mindfulness. Mindfulness is the big thing right now. I wish I could practice it better. I think it's an incredibly helpful adjunct in almost any life process. And if we would all just slow down and actually enjoy this minute of seeing you guys there and being here and trying to help our patients by doing this, it really makes life a lot easier. So mindfulness, I think, is very important. Acupuncture, surprisingly effective, okay, for migraine. It requires, like pharmacology, repetitive treatment. It's not just that you can have one acupuncture appointment and never have a headache again, but repetitive acupuncture therapy. We usually go twice a week for about 6 weeks, 12 visits, and then we can slow it down and sometimes build it back up and slow it down. But I really believe acupuncture has an excellent response. Now, there's some new areas that are quite interesting that have been just recently approved. Stimulation. There's a device that's a transmagnetic stimulation device, or TMS device. And this emits a magnetic pulse. And it's FDA approved now for aborting or getting rid of migraine with aura. Okay. But we're using it actually prophylactically, where you can pulse the brain with this magnetic pulse, and it comes a little machine that you rent or purchase, and you do it 4 pulses in the morning, 4 pulses at night, and that seems to work really quite nicely. There's some other neural stimulating devices that have small studies that show they work. The Cephalae is one of them, for example. There's some research being done on vagal nerve stimulation, stimulating the vagus nerve here for cluster headache, a different kind of headache, but multiple complementary agents through use of stimulation, etc.
Well, I think one of the most exciting things about your approach is that it's all inclusive. I know when my patients come in, they feel very helpless and they almost feel like a victim to their own life. They don't know what they did, what they didn't do, what they ate, whether it was their sleep. They feel like their own life could give them a migraine headache that's going to take them out at any minute, and they can't identify it.
Right.
So the journals that you do, the biofeedback, the nutrition, the medication, I think this is so key to actually helping people be the CEO of their own health and get control over their migraines.
Exactly. You just mentioned the biggest word, and that's control. It's changing the locus of control away from the patient, the headache, where the headache controls the patient, to the patient controlling the headache. Now, one of the things I have to emphasize is when we have a migraine, we can get rid of it and have the patient fully functional within 2 hours. That's our goal. That's the standard. That's the gold standard. If you have drugs, like Pedram mentioned, of Imitrex, but there's 7 or 8 triptans on the market, or even if you're taking your Excedrin or your Tylenol or whatever if that works for you, you need to be pain-free and fully functional, back to work in 2 hours. If you're not, your treatment is not being done correctly, or you're not taking the drug early enough. So human beings have this thing. Okay. And even the 3 of us are somewhat to blame, because we keep moving. We're saying, well, let's not talk about the pharmacology. Let's talk about the alternatives, the this is the that. But the pharmacology is so effective and so safe, okay, for the majority of people, that we need to take it in the first 30 to 60 minutes of the headache starting, and your headache will be gone. Okay, provided you're not taking it every day and getting rebound, then you need to be on prophylaxis. But the emphasis I'm making here is, as human beings, we can take back control by doing the right thing, treating early, as well as changing lifestyle processes, eating healthily, exercising, etc. But it's really, really important that if we're going to use pharmacology, we use it appropriately, in the right dose, at the right time. Very important.
This is a huge point. And I know we're running out of time here, but I really want to speak to this a little bit more, because so I'm on the alt side, right? Acupuncture, this has been my world for a very long time. And patients come in constantly wanting to get off the drugs, but are mismanaging their own dosing, right? They're not listening to their physician's orders. And so then they get this breakthrough pain and it becomes a very big deal. So on the alt side, I've seen this. I mean, I wish I could treat cluster headaches as well as oxygen could. I just can't. There are things that work well, that we know work well. And so use those. And then, so my question to you would be, if someone is under conventional pharmacological care and they want to start modifying lifestyle and diet and all these other things, how can one potentially phase out the drugs in a responsible way? And for some, we know that it might never happen. They're just, it's where, you know, and it's just bad luck maybe, but how can we phase out of the drugs and move into a healthier lifestyle and possibly see those results in a responsible way?
Well, again, I sit down with my patients at day one and I say to them, my goal number one is you need to be off your narcotic, off your barbiturate, off your benzodiazepine. Otherwise, all of my treatment, no matter what I do, is not going to work. And so I say to them, this is how we're going to do it. We're going to keep their diary, see how much you're taking in an honest fashion, give it to you by the clock, and over a period of time, taper it off. Okay? And that's a absolute 100% across the board. There is nobody who has migraine headache that's on narcotic or is on barbiturate or is on benzodiazepines long-term in our office. Nobody, because it just prevents you getting better. So if you don't want to come off the drug, if you believe that your morphine and your methadone and your Vicodin is essential, fine. I'm not your doctor. Okay. You find somebody who's going to let you do that. I just don't do that. Okay, so that, because it is so clear in the studies that affects it. Secondarily, we start them on their medications, and if as they start to do better, as you start to see the diaries and you enhancing their compliance, etc., you encourage them all the time. If you do everything, I'll get you off the drugs. Usually within 6 months to a year, let's say a year, 70% of our patients are off pharmacology. Okay, they might still use an abortive agent once or twice a week, but they're off their daily pharmacologies. Okay, so we can get patients there, but they have to be compliant in other areas. And other patients are saying, listen, I'm a busy whatever I am, okay, and I don't want to worry about these headaches. Just give me the drugs and I'm fine. And fine. Then you take your topiramate at nighttime, or you take your venlafaxine or your beta blocker or whatever it is, and you're perfect and your headaches are controlled and we've given you back your life. So everybody's an individual. There's no one treatment for every human being. You have to look at people individually, their mindsets, their emotional processes, their sensitivities to drugs, etc., and then modify care accordingly.
Well, I think that there's a part, you know, I'm an MD and I'm board certified in naturopathic medicine, but I do kind of come from the West. You can't undo all those decades of training. And I think there's such grace in realizing it's not your fault. There is a genetic component to this. You don't have to wait until it's bad enough.
Yes.
Because if you take that abortive medication, as you're saying, early on, you'll be able to take less medication. Okay. And this event will last a lot less long.
Yes.
I always say to my patients, you would never tell a child, well, just tough it out and get to the point where you're vomiting and it's so bad that you can't stand up, then take the medication. You would never do that to a child. So we have to understand that it's not your fault. This is something you're going to have to deal with, and there are safe medications to lessen the overall toxic load.
And, you know, and I tell patients, just because it's natural or it's not, it's over the counter, doesn't mean it's better or it has less side effects. You know, there are many drug interactions of those supplements that are really bad for us, and too much of many of those agents are not good for us. So I treat a herbal intervention just as carefully as I treat a pharmacologic one that's FDA approved. And I use many of them, and you know, I love boswellia, I love curcumin, I use all sorts of other papaya extracts. I use lots of anti-inflammatory processes that are, you know, not needing a prescription, but actually have a pharmacology that we understand. And that pharmacology is very similar. For example, boswellia has an activity very similar to indomethacin, an anti-inflammatory. So again, use these things knowing how they work, why they work, and have respect for everything we put in our mouth, not just because it's natural or not controlled.
Sure. Yeah, the liver's got to clear it anyways. So
Yes.
So Doc, we're just wrapping up. You're at Cedars-Sinai, which is obviously local Los Angeles. We have listeners all over the world, and so I'd love for people to know where to find you. And also, just quickly, I love this interdisciplinary story. My wife's a dentist, right? So how does a dentist end up becoming a migraine specialist? I opened that loop. I want to make sure we close it. In closing here.
Yeah, I mean, it's a nice story because I was the third dentist ever trained in the United States many years ago now, 30 years ago at UCLA. Just through the vision of the people who invented multidisciplinary pain management, probably the godfather of multidisciplinary pain management was John Bonica, an anesthesiologist. And he said, if you present to an anesthesiologist with pain, they'll block you. The neurologist will give you a drug. The physical therapist will mobilize your neck. The psychiatrist will shrink you. The ENT will clean out your sinuses, and so on. So put everybody together in one room and let them talk and let them have a dialogue where we actually talk about the same message and the same process. And I was trained in a multidisciplinary program at UCLA. Now, dentists traditionally treated pain from the eyes down and neurologists from the eyes up, okay? But the nerve that supplies all three of those areas is the trigeminal nerve. It's a single nerve. Okay?
Totally.
So you can't treat one division of a nerve and not the other division, because really, where are you managing pain, whether it's trigeminal neuralgia, as you mentioned earlier, or migraine? It's a process that's gone from the periphery to the central nervous system, or from the central nervous system to the periphery. And so if you're dealing with trigeminal nerve distribution pain, you're dealing with migraine, and you're dealing with temporomandibular disorders, and you're dealing with anything that's in the head and face. And so if you're trained in managing this, you have to come from a background that's a little different. Now, what's the big advantage of this, me being a dentist over a neurologist, and many neurology friends of mine, we talk about this, is that I treat the TMJ problems, I treat the lower half, I treat the muscular problems, which are, again, perpetuating factors in migraine, as well as the ability to use the pharmacology that works in the brain.
Love it, love it. How do people find you? How can people follow your work?
I'm at the Pain Center at Cedars-Sinai Medical Center. You can go to the website, the Pain Center, Cedars-Sinai Medical Center. My phone number is 310-423-9600. And I'll just make one more plug. I'm on the board of the American Migraine Foundation. It's an excellent not-for-profit resource site for patients with migraine. And if you need a referral to somewhere other than in Los Angeles, that's a nice resource.
Love it, love it. I know you got to get back to patients. We really want to thank you for your time. This has been really informative and excellent. So thank you so much for the work that you do.
Thank you. Nice to meet you both.
Cheers.